All right. So my name is Rebecca Katz, and I am an associate professor in the Department of International Health at Georgetown University and the co-director of a new Center for Global Health Science and Security. I spent better part of the last 10 years working on implementation of the international health regulations, and that has morphed somewhat into studying the global health security agenda and policies for pandemic preparedness. I'm very thankful to be here today, as well as, I will admit, a little overwhelmed. I did my MPH at Yale while you were dean. I am currently funded by 3 of the organizations that previously spoke, so I'm just going to get through this. Anyway, I was asked to speak about the global health security agenda, and several of the speakers, the sponsors of this commission spoke a little bit about GHSA, but what I'd like to do is provide a little more detail about GHSA itself, and also some thoughts on possibly what comes next. In my remarks, I have all sorts of background information about the threat. I have really pretty slides on the threat. I didn't think this committee needed that. But I think to very, very briefly summarize, obviously we know that worldwide infectious diseases continue to be leading killers, that many countries lack the essential resources and appropriate health infrastructure to monitor, report, and respond effectively to these disease threats that have the potential to harm the public's health. And certainly we've seen since the beginning of the 21st century numerous emerging infectious disease outbreaks, including SARS, H5N1, MERS, Ebola, and Zika. And we've seen these diseases spread across national borders, and the world continues to be at risk for pandemics. The agreed upon estimation is that we'll see one large-scale event once every 100 years, and some type of smaller type event at once every 40 years. Now, the consequence, we also know that the behavioral and environmental changes create new risks for the transmission of zoonotic and vector-borne diseases, and our globalization interdependence makes the idea that a threat anywhere is a threat everywhere. So we know this. What are the consequences, though? So obviously, if we think about a pandemic type event, there is the obvious morbidity and mortality associated with that. Everything you've ever seen in a zombie apocalypse movie, the crisis, the disorder, but there's also a huge financial cost. And in the last couple of years, there's been more and more interest in trying to actually predict exactly what that cost has been, what would be. And the current estimates are that a severe flu pandemic could result in over $3 trillion in global economic losses. Not so much from the disease directly, but from consumer reactions, labor shortages, and widespread failures in economic and financial sectors. And that risk ends up to be calculated at about $52 billion annually. Yet, the other side of this analysis is that it would cost about $3.4 billion a year to permanently create global infrastructure in every country to prevent pandemics everywhere. So if you're doing the cost-benefit analysis in your head, you should be noting that the benefits preparedness win. So where does that leave us? Well, we go back a little bit in history, and we talk a bit about the international health regulations. And in 2005, the member states of the World Health Organization acknowledged the need for global governance of public health emergencies. And the best way to combat these biological threats was for nations to build their own national capacity for early detection, comprehensive reporting, and rapid response across all sectors and all levels of health systems. The World Health Assembly adopted the revised international health regulations in 2005. They entered into force in 2007. And they represented an international legal instrument that is now binding on 196 states parties, including all member states of the WHO. And they acknowledge that public health incidents can pose threats beyond national borders. and that member states bear a responsibility to global community to identify, report, and when possible, contain public health threats before they become public health emergencies of international concern. Implementation, though, of the international health regulations has been difficult. This is a treaty obligation, so it is binding on a country, yet it falls almost entirely to the Ministry of Health to actually implement. And health ministries were tasked but not necessarily empowered to make changes. There was a lack of awareness on the part of national leaders, and thus building the types of capacities that are required under the IHR remained a relatively low priority. And there were fragmented objectives and milestones. So in 2012, when nations were supposed to report to the WHO whether they had complied or not with their obligations under the IHR, 21% reported that they were in compliance, and 2 years later in 2014, that number went up to 33%, which was mentioned by a colleague from CDC earlier. And you still have a whole bunch of countries that aren't even reporting. So this is the situation which the context for the emergence of the global health security agenda. It was this idea that we need to do something to engage actors beyond health, to raise the priority of global health security amongst political leaders, and to create shared milestones and goals for all partners. So after several years of planning, the Global Health Security Agenda was launched on February 13th, 2014. Where the United States joined 28 other countries, OIE, WHO, and FAO, to launch the Global Health Security Agenda as this idea of a shared commitment to accelerate implementation of the IHR and other relevant agreements that affect global health security to advance progress towards a world safe, secure from infectious disease threats. I'm reading the tagline. To bring together nations to make new concrete commitments to achieving shared milestones and capacity building, and to elevate global health security as a priority for national decision makers worldwide. There's now a total of 55 countries that have signed on to this initiative. It's important to note, though, that raising the political profile of global health security is a heavy lift. But GHSA has been tremendously successful in doing so. We now have heads of states that talk about global health security in a way that never happened before. Now, it's not GHSA alone. This was certainly helped out by some scary emerging infectious diseases. GHSA predated the Ebola outbreak, but the outbreak itself certainly sharpened the attention of world leaders. As part of GHSA, and this was mentioned earlier, there are a series of action packages. These are specific measurable targets, around 11 categories for prevention, detection, and response at the country level. And ideally, these areas of work are to be built to create a public health infrastructure, but that public health infrastructure only works. It means very little unless there is a functional healthcare system at the base. And we've seen also that even the best surveillance system, it's not terribly helpful if there's no clinical care available. So to speak specifically about what the US is doing under GHSA, the US has made bilateral commitments to 32 countries in the Caribbean to help develop national strategic plans that they called roadmaps, and to work to build health security capacity. There's two phases. There's phase one, which has 17 countries in it, and those countries receive financial assistance in all 11 action packages. And then there's a series of countries that are called phase two, which means that the US will work with those countries to develop these roadmaps and to provide technical assistance, but not necessarily financial resources. This commitment to assist these countries was met by the G7 partners. And there's now a total collective commitment to assist 76 countries to implement core capacities under the IHR through the GHSA action packages. In the US, as we've heard earlier, GHSA is being implemented primarily by CDC, USAID, DoD, and Department of State. In CDC, again, as we heard, this is expertise. They're providing expertise related primarily to strengthening laboratory systems, improving indicator and event-based surveillance, training the public health workforce, and developing response capacity through emergency operations centers and emergency management capabilities in general. USAID, again, heard earlier about some of the work that they're doing, but I think slightly differentiating factor with AIDS assistance under GHSA is looking at looking to detect viruses with pandemic potential, and specifically looking at the One Health intersect. Again, we also heard from DoD. Most of GHSA, I believe, is being done through the Cooperative Biological Engagement Program, but certainly is consistent with much of the other work being done in terms of broader global health engagement. And the Department of State also, most of the implementation work is also being done through the Cooperative Threat Reduction Program and supporting safe and secure use of biological materials and equipment necessary to combat infectious diseases. And then you also have FBI, DHS, and agriculture is also involved in their own ways as well. Now, part of GHSA was the idea that you would actually be able to measure success. And early on, there were 5 pilot assessments that were done. And in early 2016, WHO published a new tool. It's called the Joint External Evaluation Tool, the JEE, which combines global health security assessment matrix format with a series of assessment questions based on the previous IHR monitoring framework. So there is now a single evaluation tool that is being used by the WHO for IHR implementation, but it integrates the entire GHSA action package metrics. It can be used voluntarily with an external team coming in to evaluate your country or using it for self-assessment. The measures are not perfect. In fact, I actually would argue that they're far from it, but it's what we have right now. And it is a single assessment tool, so countries are not being over-assessed. And hopefully there is space to continuously improve it as we develop real, maybe more accurate measures for global health security. But countries are signing up. There have been about a little less than a dozen countries have actually completed this JEE. An additional 53 are either scheduled or the countries have actually expressed interest. The problem is it's not clear who's going to actually pay for them and if there's even resources to do as many of these assessments as countries who have signed up to do them. And to me, there's a major question of actually then how the countries utilize their findings. So great, we have this assessment process, and then now what? How do we actually operationalize the findings into making real change? There is something called, there's an Alliance for Country Assessments for Global Health Security and IHR Implementation. So this is a group that's supposed to support the JEE assessments. But I'm not sure that many in the Alliance have actually offered up funding yet. It's a combination of governments, foundations, and other private sectors, and the US estimates that it would cost between $8 and $10 million a year to effectively carry out these external evaluations. And there may be about half of that in the committed resources. Speaking of resources, it's worth noting how GHSA is being funded. In 2014, the White House announced a commitment of $1 billion to support these core capacity building under GHSA. And there was a one-time appropriation, and this was done with the Ebola appropriation. CDC received a little less than $600 million to advance the GHSA. USAID received another $200 million, and state received additional funds to be expended over a period between 3 and 5 years. In other countries, the funding being allocated to these commitments is a mix of new and old money. It's not actually entirely clear how much of this is new money. And I think there's part of it's a little confusing because there's a lot of countries and honestly some of our programs that we can claim is taking credit because it matches the same objectives under GHSA, but it's not necessarily a brand new program. and maybe it would have existed anyway. And maybe the project we have going on in Kenya on LabCap that we have had going on for 5 years, now we can count at this thing. So it's actually, the financial auditing is missing. And maybe hopefully will happen soon, since I think it'd be important to actually be able to track what's new and what's old. And what particularly in thinking about how an initiative like this can mobilize new resources. So where are we now? Again, this is this partnership of 55 nations, international organizations, and non-governmental stakeholders. We can clearly say that GHSA is facilitating collaborative capacity-building efforts to try to achieve these specific and measurable targets. The roles of those 55 nations, though, vary pretty dramatically, and I think, you know, some of them are donors, some are what we'll call leading an action package, or signed on to an action package. And there's a sense that some have signed on in part because they think that by doing so, they might become a recipient nation. And there's, I think, a decent amount of confusion among some countries about actually what the difference is, and what it actually means to be part of GHSA. But there certainly have been major successes, and it's for those of us who've been working in global health security for a long time, it's almost overwhelming how great those successes are, that you go to international meetings and everybody's talking about this thing. And it's political leaders. This is part of the G20 communique. It's very much raised to the very highest political levels, and that's really exciting. Money is certainly flowing to capacity building efforts. CDC has dramatically expanded its global health presence. And the interagency now talks in action packages, for better or worse, but it's like the language. So I think there's really interesting questions, though, about what comes next. When GHSA was launched, it was launched as a one-time 5-year initiative to accelerate progress towards IHR implementation. It was a one-time appropriation. Yet we have agencies and organizations that are basically reorganizing themselves based on action packages. So I think there's some really interesting questions to think about what actually comes next. This was a presidential initiative. Will it be adopted by the next administration? Is there historic precedent for programs that are presidential initiatives to either die off, be renamed, or I think only occasionally survive? But if we think about what comes next, no matter what comes next, we still need funding, outreach, improvement in measurements, continued mobilization in order to support this much-needed capacity building that meets the obligations under the IHR, that makes the world safer, that protects population health, that enables us to collectively respond to pandemics. And do we have a program that actually addresses these problems in every country? No. I mean, I think the other important piece about this is that how those countries on the list that are receiving assistance were selected. You know, are they selected because of hotspot analysis? Were they selected because, you know, we think through predictive modeling that they may be the next location for the next emerging infectious disease? Or were they selected based on previous strategic relationships? No one's giving money to Suriname. I mean, it's just a question of thinking about where are we investing our resources, and not being too naive about why we give money to the countries we do. But I think it's an important landscape to take a look at. So if this is not adopted by the next administration, I think that's okay. And I think it's though essential to continue capacity building efforts in coordination with other nations, but it can be done under lowercase GHS. It can be done under global health security. I don't think we need the actual initiative for it. People are looking at me like I'm crazy. I mean, I think we can focus on the core cores, the surveillance, laboratory, response, human resources, and looking at how building national capacities actually links with the international efforts and frameworks that are being done in other fora. We can look at existing programs that were around before GHSA, yet have similar focus, and maybe kind of double down on those. So at CDC, maybe even re-examining the global disease detection program and thinking about the difference between having a regional platform for building capacity versus a presence in every country. There was the Emerging Pandemic Threats Program, and that has morphed at USAID to look at Predict2 and the One Health Workforce and their preparedness and response program. And all of those stand alone apart from GHSA. They are part of it, they support it, but all these programs stand alone no matter what. There is DoD's massive global health engagements efforts and all of the health aspects of the CTR programs. But no matter what, it's all going to have to be funded and coordinated. And I think if nothing else comes from GHSA, it has produced a process to coordinate country engagement in key global health areas and key areas of global health security. And if that can be sustained, I think that would be a real benefit to the interagency as well as to the global health community in general. But I would also emphasize that we really need to focus on metrics and best practices. And while we have something, I view them actually more as placeholders than the real metrics that we should end up with. So anyway, I'm hopeful that we will continue our focused attention on global health security, but I want to make sure the focus is on the issues and not necessarily the specific initiative, since global health security, I think, is too important to be ignored. So let me end there.